To introduce the next set of presenters, please welcome Dr. Jhade Peneyra, past president of the Philippine Society of Medical Oncology and chairman of the section of Medical Oncology at De La Salle University Medical Center, Philippines.
Good evening, ladies and gentlemen. I'm Dr. Jhade Peneyra from the Philippines, who will moderate this session. And so to continue with the Asian Oncology Society Conference on Research presentation, it is with great pleasure that I introduce the presenters for this segment and the respective research titles one by one. The first presenter is Dr. Alfred Jatho from the Uganda Cancer Institute, Mulago Hospital. He will talk about his research entitled Integrating Primary Prevention and Early Detection of Cancer in Primary Healthcare in Uganda. The next presenter is Dr. Nghia Trong Doan from the University of Medicine and Pharmacy, Ho Chi Minh City, Vietnam, who will talk about laparoscopic radical hysterectomy for early-stage cervical cancer. The third presenter is Dr. Gracieux Fernando from the University of the Philippines, Philippine General Hospital, who will share with us a research entitled the Asian Sarcoma Consortium Sarcoma Preceptorship Program. Ladies and gentlemen, please welcome Drs. Alfred Jatho, Nghia Trong Doan, and Gracieux Fernando.
Yes, I'm Jatho Alfred from Uganda, Uganda Cancer Institute. At the same time, a PhD fellow at National Cancer Center, Graduate School of Cancer Science and Policy. I'm presenting on capacity building for integrating primary prevention and early detection of cancer into primary health care in Uganda. In 2018, out of 60,000 Ugandans estimated to be suffering from cancer, only 5% of them can access cancer care at the only comprehensive cancer center in Uganda. And also 77% estimated to be presenting with a late-stage disease where prognosis is expected to be poor, and therefore the treatment becomes costly. So in this program, we aim to build capacity to integrate primary prevention and early detection of cancer in the district primary healthcare facilities. And we thought this could be pivotal in addressing disparity in cancer prevention and early detection. So in 2017, we started by conducting 2 national and 6 regional cancer control stakeholders consultative meetings, whereby the stakeholders advise on what are some of the requirements needed to properly integrate cancer services in the primary healthcare facilities. So they made a number of suggestions, including development of specific materials that are culturally appropriate and the reference material for the health workers, and training critical health workers to be able to start these activities at the primary healthcare facilities. So in 2017 and 2018, we developed print and audiovisual cancer education materials for both health workers and the community, with the main focus on primary prevention of cancer and early detection of cancer in those facilities. As far as the result is concerned, a total of 488 health workers from 118 districts were trained. We went ahead again, selected one part of one sub-region in Uganda, which we call the East Central sub-region, where 6 districts were selected for pilot training. In those pilot districts, we trained 46 health workers to provide routine cervical, breast, and prostate cancer screening on daily basis in those facilities. And we think we can next time replicate this from the pilot centers to other parts of the country. And then at the same time, we developed 32,800 cancer information material tackling breast, cervical, prostate, childhood cancers, and general cancer information. At the same time, health education guide and a referral guideline for suspected cancers to help these primary care workers to be able to take decision in appropriate referral for the suspected cancer cases, even if they're not able to confirm them at the lower level health facilities. If further develop material for the communities, including audiovisual materials that were circulated through Facebook, WhatsApps, and then the local radio station to be able to create awareness to those who are unable to read and write and the general population at large. At 1 year, we conducted a follow-up and we found that 75% of these districts that participated in the training at least were implementing one of the actions we agreed on during the training. And then the pilot sites were also conducting routine education and screening in their hospital facilities. In this table, you can see during the regional consultative meeting, a total of 283 people attended this regional consultative meeting representing all the major regions of Uganda. That's the East Central, Eastern region, the West Nile and the Northwest Nile, Western region, Central region, Northern region, including a sub-region called Karamoja, totaling to 283 participants. Here I'm showing the reference material that we developed for the health workers to guide them in providing appropriate information for the communities as far as basic primary prevention and early detection of cancer is concerned, based on low-cost technology options recommended by the World Health Organization. We further developed posters and brochures for people who can read this information so that they're able to get more information. In this table, I'm showing the different material that we distributed to the primary care facilities through their district health management and the regional referral hospital, the health training institution, totaling to 32,800 materials. Here I'm showing you the audiovisual clips that we developed. The one on the breast cancer, cervical, and the prostate. Why these three? Because these three are the leading cause of cancer incidence in Uganda and mortality compared to other types of cancer. So we started from the most common types of cancer, then we shall continue developing more material on other types of cancer that are among the top 10 causes of cancer-related deaths in Uganda. Here in this table, I'm showing now the assessment, because we did pre-training and post-training assessment of these health workers that participated in this training, so that we are sure that they are going back home with adequate knowledge and skills that are able to introduce, integrate primary prevention, early detection of cancer in the primary care facilities. Here you can see there was a good improvement in terms of the difference between the pre and the post-training assessment. Here I'm showing a map of Uganda showing the different regions that we tackle. We aim at addressing all the districts. That is utilitarian principle, maximizing benefit for the biggest number as possible. But we thought actual screening routinely require more skills, require more material and support. So we selected the East Central part of Uganda, which at times called Busoga and Samia sub-region. So we group the two subunits as East Central sub-region, where pilot screening is taking place. And we did follow up. They are doing excellent jobs. In terms of conclusion, in Uganda, the unmet needs of cancer control services are enormous. And therefore, integrating primary prevention and early detection of cancer into primary healthcare facilities is paramount. One key message for COVID-19. Approach COVID-19 with strict adherence to hospital infection control measures for all health workers, patients, and visitors, and move on. Thank you so much for listening.
Dear ladies and gentlemen, I am Dr. Doan Nghia, coming from Oncology Hospital at Ho Chi Minh City, Vietnam. Today, I feel very pleased to participate the first video international conference of Asian Oncology Society. On behalf of our department, I will present the study named the Laparascopic Radical Hysterectomy for early-stage cervical cancer. The first of all is the background. As we know, in the end of 2018, the phase 3 LACC trial showed that minimally invasive radical hysterectomy in early-stage cervical cancer were associated with lower rates of disease-free survival as well as overall survival. However, this trial did not have enough power to generalize to low-risk patients. Moreover, recently, the sugar cohort observation study showed that the differences of survival were not significant in patients with tumor smaller or equal than 2 centimeters in diameter. Therefore, we think that the laparoscopic radical hysterectomy is still being considered in that context, and we performed this study to initially evaluate the laparoscopic approach for early-stage cervical cancer in our hospital. The next is the material and methods. Our study was a retrospective trial. We reviewed the data of early-stage cervical cancer who were underwent laparoscopic total hysterectomy at Oncology Hospital at Ho Chi Minh City from June 2016 to January 2019. The primary outcome was the operation outcome, including the operation time, the blood loss, the time of recovery of poor wealth, and the time of removal of urinary catheter, as well as the rate of complication. The secondary ones was the rate of recurrence. The next is a result and discussion. During the time of study, we enrolled 75 patients. The average age of patients was 42 years. According to the state 1B1 was the most common state, according nearly 90%. And squamous cell carcinoma was the most post-operative pathology, accounting nearly 68%. Nearly 34 patients were performed radiation. Among them, 19 patients were performed preoperative radiation, and 7 patients were performed adjuvant radiation. According to the operation outcome, the mean of operation time was 190 minutes, and the mean of blood loss was 150 millimeters. However, there were no kinetic blood transfusion. The time return of poor well function and the time of removal of urinary catheters were 2 days and 6 hours respectively. Compared to the other study over the world, we found that the operation outcome in our study were similar or better when compared to the other over the world. The rate of surgical complication in our study was 14.6%. Among them, there were 2 cases of bladder injury, 7 cases of ureter injury, and 2 cases of bowel injuries. However, all the complications just happened in the first hour, 30 cases. After that time, we had not had any complication within this array to the learning curve. The more cases we perform, the fewer complications will happen. According to the oncology outcome, the Y of lateral parameteron and vaginal machines were 2 cm and 3 cm respectively. After 12 months of median follow-up time, we note 2 cases of pelvic recurrence. There were no cases of metastasis and 9. According to the data, we found that laparoscopic total hysterectomy in early stage cervical cancer is a safe approach in women with low risk disease. It reduced the operating morbidity as well as increased the quality of life. However, the limits of our study were that the follow-up time was still short. Therefore, we will continue this study to explore the disease-free and overall survival rates, and we hope we will have opportunity to show the data in the other conference in the near future. The last thing I would like to say today is that the COVID-19 pandemic is becoming a public health emergency of international concern. The oncology patients are the unique population in that they are vulnerable to COVID-19. Therefore, we need to enhance the recovery of our our surgical patient, and I think the laparoscopic approach is a good option for this purpose. Lastly, thank you for your attention.
Good evening, everyone, and my thanks to the AOS for the privilege of presenting our study in this venue. These are my disclosures. Soft tissue sarcomas are uncommon tumors that are rarely seen in general oncology practice. This diminished experience results in poor survival outcomes. The Asian Sarcoma Consortium is a group of sarcoma specialists whose aim is to increase awareness on sarcoma management by pioneering a sarcoma preceptorship program. The goal of this study is to evaluate the program using the first 2 levels of the Kirkpatrick model. Specifically, we wanted to determine the general impressions of the participants, their satisfaction with the program's content and manner of conduct, and the degree of learning obtained after their participation. This was a two-day program held at the Academia of the National University of Health in Singapore. The faculty was composed of the members of the ASC, and the activities included didactic lectures, multidisciplinary case presentations, and summative case presentations. The program received sponsorship from Novartis Pharmaceuticals, and this study was limited to only short-term outcomes due to the heterogeneity of the participants and the problems with long-term follow-ups. The initial program had 30 participants from 16 countries. Majority were doctors who practice in a university or government hospital setting. 43% were medical oncologists, and there was an equal distribution between consultants and trainees. Levels of satisfaction were evaluated by a satisfaction survey tool. Results of the satisfaction survey showed that they were highly satisfied with both time for the sessions and the scope of the topics. Most felt that the sessions were helpful to them in their clinical practice. Most were also highly satisfied with the expertise of the speakers and facilitators. And in a separate survey conducted by the sponsor, participants highly rated the program in terms of objectives, opportunities for interaction, relevance to practice, ability to address issues that improved competence, practice changing behavior, and freedom from bias. Assessment of knowledge was done via a comparison between a pretest and a post-test. For the sake of objectivity, the same test was administered. Results revealed a higher pretest average score of 13.4 points versus a post-test average score of 11.4 points. Computation of the test reliability coefficient revealed that the pretest was both homogeneous and reliable, while the post-test was unreliable. Since the same test was administered, the difference was attributed to external factors, of which time played the biggest effect. Weak points raised by the survey included time management, preceptorship content, language barriers, and inconsistencies in the handling of the case discussions. Recommendations for future programs included the structuring of content to fit the time frame, concentration on must-know topics, the restructuring of the multidisciplinary case discussion to clarify the rules, to limit the number of cases, to emphasize interactions, and to create heterogeneous small groups, and to budget time for evaluation of activities. For evaluation, recommendations included revision of tools to capture relevant data, development of an online tool, factor time for evaluation activities, utilize the data from this evaluation for future programs, and to publish the results of the evaluation, focusing on the lessons learned or as an exercise in improvement for future programs. Thank you very much.
Fine,
Welcome
thank you.
everyone
Fine.
to the last
Thank you.
live
Thank you.
Q&A of the oral research presentation, day 5 of the AOS. So here with me is Dr. Fernando, Dr. Doan, and Dr. Jatho to answer all your questions regarding their oral research presentations.
Okay.
Okay. So while waiting for the messages to come in, let me start with Dr. Alfred Jatho.
Good.
Okay, yes.
Yes.
Thank you very much
Yes.
for that relevant paper regarding the
Thank you.
screening and early detection. But
Yes,
when
yes.
you, I would like to ask, I was wondering what challenges did you encounter when you started out this campaign of screening and early detection, especially in referring these patients from the primary healthcare system to the tertiary institutions
Yeah,
in
the
your
challenge,
local?
yes,
Yeah.
the challenge we have now, and we are addressing it, is the ability of the referral site. That's the tertiary hospital, the regional referral, and the national referral to absorb the increase in demand of services. Because earlier on, people were presenting with the late cancer disease, so the only option would be to reach the primary healthcare facilities, train the health workers there, so that they're able to recognize whether we don't have enough money for screening, but they can recognize the early warning symptoms of cancer. There's what we call in early detection, there are two strategies. Screening, which is very expensive, as we know, and then what we call early diagnosis. Early diagnosis means train the primary healthcare workers, including even the village volunteers, on how to recognize some symptoms of cancer so that they're able to educate the communities. Then people will respond on the recognition of such symptoms and then present themselves to the health facilities so that additional tests can be done to confirm whether it is cancer or not. In doing that, you can downstage cancer, and it is the cheapest option of early detection. But many people think cancer is very expensive, you can do less, we are a low-income country, thinking only on the screening strategy. Screening strategy alone is very expensive. So in this model, we look at the two aspects of early detection. Screening for the most common types of cancer, that is cancer of the cervix and breast, because there's evidence for that. Even they have low-cost alternative, like using visual inspection with acetic acid, which you can afford as a country. But other types of cancer, including this one that you can screen, to maximize the benefit, we need also to adopt the early diagnosis strategy based on early recognition of signs and symptoms. So what you are seeing now, there is a surge in the people seeking to confirm the cancer that they are suspecting, because the primary healthcare facility, they don't have pathology lab to do sampling.
Yes.
But now we are trying to address that. And it is also good so that we also develop the regional referral and the national system to absorb that. Instead of saying, fine, we don't have enough money, we do less, yet people are presenting with the late cancer disease. People who present with late cancer disease, we treat them right. By the time of economic analysis, we are wasting the money. You're giving chemo, you're doing surgery, you're doing radiotherapy, very expensive intervention, but the person is dying within 6 months, dying within 1 year. What is the economic gain? What's the value added? We rather maximize early detection through whatever cost it takes so that we are able to increase the number of people we can treat with the hope that we can improve their life and they go back to productivity.
Well said, Dr. Jatho. Thank you.
Yes.
We'll go now to Dr. Doan. Dr.
Yes.
Doan,
Yes, I hear
again,
you.
no, your paper is timely, especially when choosing interventions for early stage cervical cancer.
Yes.
But in your institution, did you do extra maneuvers with the standard laparoscopic hysterectomy to prevent tumor spillage? Because this is the usual problem with, I think, laparoscopies, no?
Yes.
Tumor spillage. Did you do extra maneuvers to protect the patient from tumor spillage? Yeah.
Okay, I understand your question. However, in my hospital, we have not used the extra maneuver because due to we don't have this tool until now. We just perform laparoscopy for the very low risk cervical cancer. As you know, after LACC trial results, we chose a patient very carefully. We just perform laparoscopy in very low risk cancer, and I think that in this setting, I think the maneuver cannot maneuver do not have the bad effects on the survival in this low risk patient cancer.
Yes, agree. I agree. for patients, especially for early stage cervical cancers. I think we need more data regarding the benefit of laparoscopic interventions. Thank you, Dr. Doan. Let's go now to Dr. Ding. May I ask, no, regarding your workshops, no, for the sarcoma management, did you see any significant or any problematic issues, no, in sarcoma management among your work in the workshops, and what I mean is, are there significant gaps of knowledge, and that you really want to focus on in the next workshops or in the next preceptorship programs?
Well, actually, what we would focus on would depend on the type of audience that we would have. Right now, one of the biggest concerns of most sarcoma specialists is the detection or the diagnosis of sarcomas. And as you know, in cancers, the diagnosis depends on the type of biopsy that you're going to get. And some of the problems that we've encountered is that in the initial encounter of a sarcoma patient, particularly with the specialists who are not sarcoma experts, if they do not have a high index of suspicion that the disease they're dealing with is a sarcoma, the chances are is that they would do a biopsy in which they could potentially contaminate sites so that a limb sparing or a wide excision that could lead to a cure for the patient could actually be compromised. So one of the issues that we would like to emphasize is the proper diagnostic sampling of sarcomas. The other thing that we would like to emphasize is that because sarcomas tend to be a very heterogeneous group of diseases, and that they behave differently among the different groups of sarcomas, then there is an emerging role for molecular analysis in order to determine a more accurate diagnosis of the type of sarcoma that you're dealing with. Particularly now that we are learning that there are certain subgroups of sarcomas that may be amenable to treatments with targeted therapies or multikinase inhibitors.
Yeah, thank you very much for that, Dr. Fernando. For the last 2 minutes, are there any final comments from our distinguished authors?
Alfred first.
No more. Yes. So thank you very much. Yes. Okay. And there are no in the chat box anymore. Thank you very much for joining us again and for keeping time, no, for the question and answer. Thank you very much to the audience, no, for listening. And God willing, we hope to see you all again face to face. But for now, I will just have to shake you virtually, shake your hands virtually. Thank you very much, Dr. Alfred Jatho, Dr. Doan Trong Nghia, and Dr. Gracieux Fernando. Thank you very much.
Thank you. Good evening. Good evening, everyone.
Good evening.
Okay. And yes, I will now end this.
Thank you, everyone, for
Thank you again. And we will now end this session.
Thank you again.
Thank you very much. Good night, everyone.
Good night.
Thank you so much. Good night. Yeah, good night.